Hey, happy Friday, and it is now day 4 of the 12 days of articles in review. My name is Mary Coughlin, and I'm the president and founder of Caring Essentials. And so I'm going to continue to do this thing where I'm amalgamating different papers that I'm reading and then providing you with the references, because it makes it wicked interesting for me, and I've gotten some feedback, so I think it's being wicked interesting for you guys as well. As many of you know, this is my office. It's still too cold out, single digits. As many of you know, I'm very passionate about the concept of trauma-informed care and adapting that concept for hospitalized infants and newborns. And so I thought I would kind of like revisit this topic and present what is already known, introduce a couple of the new papers and some pretty landmark publications that I feel are relevant for our patient population and beyond. So I was, scurrying around looking for what my handful of articles were going to be, and I came across a paper that I had read a little while back by Marcek et al. It's published in 2015. I believe it's in JAMA. Let me just double check. JAMA Pediatrics. And the title of the paper was Implementing a Trauma-Informed Approach in Pediatric Healthcare Networks. And I was really struck by the way the authors present the information and really get to the point of why trauma-informed care is so clinically relevant and necessary, particularly for the pediatric patient population, which, surprise, neonatology is part of that patient population. And they talk about assessing readiness for implementing trauma-informed care, but they lay the groundwork in the opening segments of the paper, explaining the prevalence of trauma in children, recognizing the effects of trauma on all the individuals in the healthcare system. So, and I've talked about this before with you guys, certainly it's traumatic for the patient, absolutely traumatic for the family, but it's also traumatizing for us, our bearing witness to the most horrific thing that can happen to a family affects us, whether we acknowledge it consciously or not. It does definitely affect us. And so this idea of a trauma-informed approach really is a blanket of a strategy that is aimed at preserving the health and wellness of all of us, all the players in that high-stakes environment in intensive care for pediatrics and neonates as well. They also go on to then reference several validating sources that also corroborate this information that trauma-informed care is very relevant for our patient population. From the National Center for Trauma-Informed Care to SAMHSA, which is the Substance Abuse and Mental Health Services Administration with the government, the National Child Traumatic Stress Network, and several really great resources and stuff that were developed by the folks at CHOP around this idea of trauma in the pediatric medical setting. Just to, follow up about that idea of medical trauma, there was an excellent paper published 2016 in Advances by Amy DeGata and her colleagues, introducing a conceptual model that was grounded on the good work that's been done around pediatric medical trauma and introducing this concept of infant medical trauma in the NICU and connecting the dots. Again, some of it just seems like, yeah, obviously, but, it's proper for us to make sure that we're not just borrowing from Peter to pay Paul and not being, not performing that level of due diligence to really evaluate what is the level of vulnerability for our patient population. What are the sequelae? And, kind of now jumping over to the sequelae, there were several really awesome papers written by Janet Rennick and her colleagues in the early 2000s, looking at PICU survivors and identifying children at risk for psychological sequelae. And that's really what we're talking about. Certainly this hyperactivation of the stress response undermines homeostatic function, undermines, tissue repair and calorie expenditure and all that other kind of stuff. But when we're really looking at those long-term outcomes, certainly those are factors in how they, stress and all that other kind of stuff poses a threat to the lifelong health and wellness of the individual. But the psychological sequelae is often missed, at least it was in my clinical experience. I never really appreciated the vulnerability of the patients I was taking care of for their mental health wellness down the line. But Rennick and all have published several papers, getting myself all excited, about this. And she did one study, is based, I think it was in Canada, where she did a comparison of infants, pediatric patients in a ward, and pediatric patients in a PICU. And what she discovered is that there was a higher risk of developing persistent psychological sequelae in the infants that were in the PICU. And I think it was either in this paper or another paper that I also referenced, and I'll share that citation with you, that there are unique individual attributes that also predispose infants to the risk of this psychological sequela. So again, being mindful that this is not a one-size-fits-all kind of a thing. And I think, we find some comfort in that, oh, do this and everybody will be fine, versus what? Not everybody, this isn't going to bother everybody, so it may just bother a small percentage of the population. So who is it? Who do I have to be more gentle to and who do I not? Well, you got to be gentle to everybody. We need to take this idea of trauma-informed care and apply it to the culture of service that we provide to our patients. And again, in reviewing this, and I'm doing some work with some hospitals this year and revising my assessment tool for readiness for cultural transformation and that sort of thing, and came across this really cool paper that delineated is it 5 or 6? Hold on. Core values of trauma-informed care. And it begins with safety. And it asks the question, to what extent does your unit's culture or practice, policies, and routines ensure the physical and emotional safety of the individuals you serve? And, they ask, some more detailed questions about what does that mean? What is safety? I mean, on first blush, you may think of safety as, the 5 hours for medication administration or doing a safety pause, when we're doing a procedure and stuff like that. But safety is much bigger than that. And certainly the emotional dimensions of safety are much bigger than that. And we need to embrace that. The evidence is now too overwhelming that the emotional integrity of these individuals and their vulnerability poses a threat to their health and wellness in the short term, but even more importantly, in the long term. And, this is well supported in the paper put out by the American Academy of Pediatrics and their new framework for pediatric medicine, looking at the ecology of the developing human, the ecology being the physical and the relational or the human environment, impacts their biology, and that impacts their developmental trajectory. And so it's not just physical, it's psychosocial, emotional. And we play a big role in that, right? In how we validate their existence. And so you're going to love all of these papers. This will be if you're not doing anything for New Year's, you just sit back, kick back, pour a cup of cocoa or a glass of wine, whatever your beverages of preference, and read these papers. They're really brilliant. The second value, though, is looking at trustworthiness. Now think about that within the context of our care. They're talking about maximizing trustworthiness through clarity of tasks, that what we're doing, consistency is a fundamental component of trust, and our interpersonal boundaries and relationships with each other. So how effective is your environment in conveying trustworthiness to the people that you serve, the patients and their families? The other value was choice, maximizing parental choice and a sense of control. And how well do we do that? When we do that well, we are practicing from a trauma-informed perspective. And right off of choice is empowerment. How well do we empower these parents? And we empower them through the other value, which is collaboration, sharing the power, sharing the decision-making, all of these things. And as I'm saying this, I'm wondering if it's not sounding familiar, because these are also attributes associated with family-centered care. And one of the papers I think it was the Marsac paper, has this really nice diagram where they have the intersection of the values for family-centered care. I'm going to scroll through. It is the values of family-centered care with the values of trauma-informed care, and where they intersect is about integrating in each parent interaction, this idea of family and trauma-informed, sharing information, encouraging family presence, providing the child and the family with choices and a sense of control, considering the family's needs, respecting the family's strengths, instead of getting all annoyed about some of their challenges, which may be a reflection of the amount of traumatic stress that they're experiencing, but spinning it around and looking at their strengths, helping them transition forward and not just, stuck in their trauma, so to speak. Cultural competence, collaboration, and continuity of care. Some NICUs still have, like you're in the ICU room here, and then we're going to move you over to the step-down room, which is a whole new cast of characters and a whole new bunch of routines and stuff like that. And that can be really destabilizing and re-traumatizing to family. So being mindful of all of that. Attending to your self-care, which I think is lovely that they included this, because of course it's about all of the individuals that are involved in that high stakes environment, and that includes us and how we're affected by that. So, to kind of sum up, all of this stuff, and I think you're going to love these papers, as I already said, this idea of trauma-informed care, it's not a judgment concept, okay? I'm not saying you're traumatizing the patients and the families. It's an is thing. Having a life-threatening illness or having a baby that is in a life-threatening situation is traumatizing. We are in the trauma experience. We are sharing it with them. I'm not saying that you're traumatizing. And yes, it's a harsh word. And yes, it can make us feel uncomfortable. But a rose by any other name would smell just as sweet. By not using the proper terminology doesn't change the fact that it is a terrifying traumatic event. So we need to move past our own feelings about this and hang-ups about this and really recognize what it is that we're doing, what it is that we're a part of. Honor that, validate it, so that we can then correctly support our own self-care and bring the best version of ourselves to the care encounter, supporting our patients, supporting their families during this horrific crisis. So on that note, I'll sum up this video with that, and I'll put down my references for you. Please feel free to email me, sing up for any questions or anything, or any additional information that you might want to have about this topic. I think it's profoundly relevant for the work that we do, and I'll see you guys all tomorrow. Okay, take care. Bye.